Hello, and welcome to the webinar presented in collaboration with the Connecticut, Delaware, New York, Pennsylvania, and Virginia MGMAs. We would like to thank today's webinar sponsor, Alice G. Gosfield and Associates. My name is Erin, and I will be your host. Today's presentation is being led by Renee Russell. Renee completed the Dental Assistance course in 1988 and earned an associate degree in dental hygiene from Florence Darlington Technical College in 1992. She graduated with a Bachelor of Health Science degree from the Medical University of South Carolina in 2006. Renee is an active member of the South Carolina Dental Hygiene Association, the American Dental Hygiene Association, and the Organization for Safety and Asepsis Procedures. Renee has been selected as a Hugh Friday Key Opinion Leader. Renee was honored as South Carolina's Dental Hygienist of the Year in 2010, and she serves as a speaker nationwide on OSHA, infection control, and HIPAA. Before we begin, I'd like to review a few housekeeping items and let you know how to participate. The viewer window is on the right and allows you to see everything the presenter shares on their screen. The control panel is on the left, and that's how you can participate in the webinar. The audio panel provides audio information. By default, you have joined the webinar using microphone and speakers. If you prefer, you can join the audio using your telephone by selecting Use Telephone under the audio drop-down box. The dial-in information will be displayed, including the audio PIN. During the presentation, you can send questions through the chat box found on the left side of your screen. Simply type in your question and click Send. At the end of the presentation, we will have a question and answer session to respond to as many questions as possible. As a reminder, we are recording today's webinar. You can view the recording on participating MGMA websites. Please welcome Renee Russell.
Thank you, Miss Erin. I think I went, there we go, all the way to the beginning. Welcome, and thank you again, Erin, for that introduction. Those of you, if you didn't catch my accent, yes, I am from South Carolina. And we just hope that my voice does not get froggy and southern as we go along, but hopefully you'll be able to understand my little southern accent. And happy Friday to everybody. Woohoo is all I can say. So today we're going to talk a little bit about OSHA's Bloodborne Pathogen standard and mainly the requirements of that standard as it pertains to healthcare workers. I did want to throw my disclaimer up there, letting you know there's no commercial support for this activity. I probably won't talk about too many products, but if I do, it's for example purposes only, and of course does not reflect any type of endorsement today. So our Bloodborne Pathogen standard came about or was enacted around 1991 to protect employees from any serious illness or death as a result of any infectious material in the blood. And the three bloodborne pathogens that they specifically focus on in the standard is HIV, hepatitis B, and hepatitis C. So the standard came about and it defines and tells employers what they must do and what they must follow to protect employees that are at a risk of exposure through whatever jobs that they do or tasks that they perform while they're on working hours or during working hours. So OSHA covers, I always stress this when I go on site to clients or seminars or whatnot, if OSHA ever came into your facility, they concentrate on employee safety. That's it. So they don't necessarily, they won't check to see if you are doing any procedures in your facility if you are sterilizing your instruments properly. The only thing they will check is what your employees are doing to protect themselves from that contaminated sharp or those contaminated instruments. So I hope that kind of makes sense. People get confused about OSHA and what they do, but they concentrate on employee safety, and that's pretty much it. So they set the standards out there, to tell employers what they have to do to protect employees. I know I have a little group here today that has been studying, I do believe, some bloodborne pathogens. So I'm going to talk quickly a little bit about HIV, hepatitis B, and hepatitis C and give you a few little fast facts on them, because these are covered in that bloodborne pathogen standard. Keep in mind, healthcare facilities and employers, we want to prevent any type of an exposure, risk, or incident to bloodborne pathogens, and we want to protect our employees. So, but some fast facts about HIV and hepatitis B and hepatitis C. HIV is the virus that causes AIDS. Early symptoms of HIV resemble those or flu-like symptoms, or maybe no symptoms at all. Your risk of transmitting or acquiring HIV in a healthcare setting with a known HIV needle stick, that is with a source patient that you know has HIV, it is actually a very low transmission risk. It's only a 0.3% chance. And that is because HIV does not live out the body a long amount of time. So a 0.3% chance, the risk of a known needle stick exposure to HIV is pretty low. Hepatitis B and hepatitis C have, of course, the same type of similar symptoms of each other. You could have fever, you could have nausea, diarrhea, yellowing of the skin, yellowing of the whites of the eyes, joint pain, joint swelling. We are going to talk a little bit more in depth about the hepatitis B vaccination that's available, and healthcare workers that have been vaccinated against Hep B. There's been a 95% occupational transmission decline. So that means the hepatitis B vaccination works. So that transmission is of course, very low to none. And we'll talk about the vaccination a little bit more, and I'll tell you why. Keep in mind, though, for those of you, hepatitis B is a pretty hardy little virus, and it can actually live in dried blood on a dry surface for 1 week or longer. So very important as your employees are cleaning up their environmental surfaces and equipment and tables and patient exam tables or whatnot, that that exposure is taken away from. Hep C, there is no known vaccination at this time for hepatitis C. It is the leading indication of liver transplantation. And your risk of transmitting hepatitis C with a known needle stick is a 1.7 to a 1.9% chance. Just kind of depends on where you are in your healthcare setting. It can live in dry blood on a dry surface for 4 days or longer. I always stress about Hep C. It has been reported with a blood splash to the eye in healthcare workers. So when we talk about personal protective equipment in just a few minutes, we'll talk about goggles and eyewear and the necessity of that. But keep that in mind, that Hep C has been reported with that blood splash to the eye. So the bloodborne pathogen standard basically covers these three bloodborne pathogens in their standard and what we do to prevent and protect ourselves from that. So today I was going to try to give you some requirements of the standard and the documentation that's required of the standard. Because if OSHA ever came to your facility, there are certain things they will look for and they will check. And from Aaron has told me of the different states that are represented here today during this webinar, but there are states out there that do random OSHA audits, and they just show up. Tennessee just started some random audits the end of 2018. North Carolina is kind of big on that, and I've also heard of Virginia having some random audits that take place. So if you are audited in your facility, one of the first things they're going to ask you is they're going to want to see some of your written policies and procedures. So the requirements of the standard goes somewhat like this. There may be other requirements, and of course I pulled the ones that I knew that we could talk about in our time that is allowed today, and the ones that I know that they will check if they come on site. And the first one is going to be, we'll talk about as a written control, exposure control plan. And the one thing you need to remember with that, it has to be annually updated. So every year someone should be updating that and seeing, or have there been any changes in the personal protective equipment that is supplied, and many other requirements of that particular plan. But it does have to be updated every year, and they will check that. The hepatitis B vaccination has to be offered at no cost to all employees who have that occupational risk to a bloodborne pathogen. And then employers are responsible for supplying and maintaining personal protective equipment for employees. They're also required to offer a post-exposure evaluation and consultation follow-up if there was an exposure incident. And then we have to have employee medical records, and then training records are all requirements of the standard. The first part is the exposure control plan that I like to go over. You need a written plan, of course. It tells what employers do to provide protection for their employees. You have to list in that exposure control plan what employees are at a risk. What is their exposure risk, such as are there nurses in your facility, physicians, physician assistants, medical assistants, dentists, dental hygienists, dental assistants. All of those are at that exposure risk. So that would be how you would determine what employees have that risk. If they are clinical and they are exposed to that bloodborne pathogen, then they would have that exposure determination. Administrative staff members, not so much. And then part of the exposure control plan discusses or talks about the engineering controls and work practice controls, personal protective equipment. What do you offer to your staff? What do you offer to your employees? And then what do they do if they had an exposure? What is their post-exposure follow-up and their procedures that they would go through? Your exposure control plan has to be accessible to your employees. And of course, if they wanted a copy, I don't know that I've ever had an employee that wanted a copy, but if they want a copy of your exposure control plan, that has to be provided to them. And again, annually updated. I've already talked about that, but it does have to be annually updated. A lot of times people put these exposure control plans in place and think that that's it for the duration, and it's not. You do have to annually update that. And safer medical devices, we'll talk about that also. That is part of the requirements of the standard. So exposure determination, again, you would list all the jobs in your facility and classifications in which ones have that occupational exposure. And I kind of listed a little bit ago about who is an employee of your facility that would go there. Physicians, nurses, nurses assistants, medical assistants, lab technicians, sterilization technicians. And then another part of the exposure determination that is a requirement of the standard is you would list the tasks that you perform in your facility that creates that occupational exposure. What kind of procedures do you perform in your facility, or do you not perform those procedures? But any task, phlebotomy would be a task that you perform in your facility that would put an employee at that occupational exposure. And you would always make that determination without regard to the use of personal protective equipment. That's what PPE is. And then that personal protective equipment is going to be offered to your employees. Part of the exposure control plan, and actually another part, all this is a requirement again of the standard, are safety devices. An engineering control is definitely a safety device, and an engineering control is a device or a piece of equipment that will eliminate and isolate or remove that that bloodborne pathogen hazard from the workplace. It must be available and must be utilized. If it's available on the market, you're supposed to be using safety devices in your facility. A lot of times I don't see that in facilities when I go in. Your Needle Stick Safety and Prevention Act basically states that if a safety device is on the market, an engineering control is on the market for whatever device, sharp that you are utilizing in your facility, you should have a safety device in place. If you do not have a safety device and you're not using a safety device, then you would have to show OSHA or tell them in a written format why you are not using a safety device. You would always get feedback from clinical members, those frontline team members, on safety devices. In medical facilities, I don't find this to be a big issue. They use their little safety devices. The biggest safety device that I find that is not utilized sometimes is a disposable safety scalpel. Most are still trying to use or using the stainless steel handles with the number 12 or number 15 blades, but there are safety devices on the market for that. So you would have to demonstrate of why you're not using that safety device. 3 accepted reasons for not using safety devices, and of course one is that there's no product on the market for that sharps. It would jeopardize the safety of the patient or employee of the or the success of the procedure, and it's not more effective in preventing exposure incidents. So every year, once a year in your facility, you would need to have a sharps review of your annual sharp safety program. If that hopefully that makes sense of what I'm trying to tell you. But you have to do that every year. You look at your sharp safety, and if you don't have a safety device on that needle or that disposable or that blade, then you would have to evaluate a safety needle or a safety blade and state why you are not using a safety device. And these are the 3 accepted reasons of why they are not being used, why you cannot use them. Any reusable sharp as part of the bloodborne pathogen standard, if you're moving contaminated sharps, reusable, such as instruments, after a procedure is done, you would need to transport them from your procedure room or your clinical room to your central sterilization area. I'm sorry, I was reading a question. I got a question. Does cost play in this with safety devices with small practices? Normally with small practices, I always recommend that you would go to your whatever sales rep, whoever you're doing business with, whether it's McKesson or Henry Schein, and see if they can get you a safety device to try out without having to buy something. I always say that. Or if you're at a medical conference, dental conference, whatnot, you can find sales reps sometimes there as vendors, and they may let you try one, and at least your frontline employees can look. They might even give you a sample to take back. So that's what I would do. But cost, OSHA is not going to take that in consideration if that's what you're asking about cost. But I certainly wouldn't go out and buy one. I would try to get one as a sample. And they will give you that, some of those reps, if you can find them, or go online. So I hope that answered your question. So back to transporting your contaminated loose sharps. Again, you want them in a closed container, solid sides, solid bottoms, where instruments don't poke through, where they won't leak with blood or other potentially infectious material, and then you would transport it in that closed container to a central sterilization area. You would need to have a biohazard sticker on that container, letting everyone know that it is contaminated. A work practice control is another issue that is defined in an exposure control plan. And a work practice control is a worker behavior, something that the worker does to alter their behavior so that things that they know not to do to prevent an exposure, eliminate an exposure, such as safely transporting sharps in that closed container. This picture on the left, by the way, that is a cassette system. And the cassettes would also need to be in a closed container because the cassette is not leak proof and it does have holes in it. So the one on top is a safely transporting of sharps. So in a closed container, solid sides, solid bottoms, you would not take your sharps to the central sterilization area wrapped in a paper towel, holding it in your hand as you walk down the hall. And believe it or not, I've seen that in practices. We know not, hopefully you would know not to reach your hand into a container full of sharps. You would always want to rinse those and dump those. And then I hope you notice, and we'll talk a little bit more about utility gloves there on the left. But that worker has on utility gloves when she is handling those loose contaminated sharps. So all of that is part of your exposure control plan, along with hepatitis B vaccination. You would want to make some mention in that plan about providing that vaccination to your employees who have that occupational exposure risk. This is an OSHA requirement that you make that hepatitis B vaccination available to your employees. It would need to be free of charge at a reasonable time and a reasonable place, and within 10 days that they start their initial assignment. It is also now a requirement if you are providing the vaccine to your employees that they also are offered a titer or a post-screening 1 to 2 months after the vaccination series ends. If OSHA ever did come into your facility, they will check to ensure that you have offered that hepatitis B vaccination to your exposed employees. Now, of course, there are some that have either had the vaccination years ago, maybe they don't know the dates. I always use myself as an example. I had the vaccination series in the early, I think 1990, something like that. I guess I'm telling my age, but anyway, I'll tell you my age, but I won't tell you my weight. Anyway, I don't have the dates of my vaccination, but I do have a titer or that post-screening that said I had enough antibodies so I could supply that to any employer. You have to have something on file for each employee who has that occupational risk. Either they make a declination, or you have a declination statement saying they're declining the vaccination from your facility for whatever reason that is. That could be they had it in 1980 or whatever, but they don't know the dates. So they would sign a declination. They would show you proof of the series, or they would give you a proof of a titer. An antibody testing, if it reveals immunity, the great thing with the CDC now says that if you have had all 3 of your vaccinations, and you have that antibody testing has shown that you have enough antibodies in your system, then you have that long-term or lifetime immunity. You do not have to do boosters anymore. Thank goodness we used to have to do boosters every 5 years, and then they moved it to every 10. CDC says you don't have to do that anymore. Keep in mind, especially with employees that are coming onto your facilities, if they have only had 2 vaccinations and they had a titer that says they had enough antibodies after 2 vaccinations, because the hepatitis B vaccination is a 3 vaccination series. So you do 3 vaccinations followed by that post-screening or titer. Some people will respond after 2 vaccinations. CDC says that does not give them that long-term or lifetime, that immunity that they need. So it's very important to ensure that everyone has had those 3 vaccinations and then they responded to the titers. I have a couple of questions. One was, we have MAs that do not have any contact with sharps. Are they still considered to be occupationally exposed? That depends if they're cleaning up rooms after a patient leaves. Are they wiping tables down? Are they doing any equipment cleanup? So it just depends on whether they have an exposure, an occupational exposure to blood. If there's any risk of that, then yes, they would still be considered to be occupationally exposed. Are you required to offer the hepatitis B to all employees or just the clinical staff? And that's a great question. The requirement states that you offer the hepatitis B vaccination to employees who have an occupationally exposure risk. So if they are strictly administrative members of your team and they do not ever cross over to the clinical side, to clean a room, to clean instruments, to clean any equipment, strictly administrative, they do not have to be offered that hepatitis B vaccination. Great questions. Thank y'all for that. I think about my children who are 18 and 23, and both of them had, most people have the hepatitis B vaccinations now at birth, but they don't have a titer. So you could be offered that titer if they were a clinical member. Some people give them a booster and then offer the titers, but that again goes through whatever physician or center that you would use. It would be best what they thought was best for that particular member of your team. But you do have to have, I can't stress this enough, something on file stating that you offered it to those employees. OSHA will check this if they come into your facility. That's a definite thing they check. So personal protective equipment is another issue that is addressed in your exposure control plan. And I'll go over the personal protective equipment. Of course, as you see in these pictures, I'm hoping you're seeing a couple of errors here and things that are wrong with the personal protective equipment. But personal protective equipment are gloves, masks, eyewear, lab jackets, lab coats, and or utility gloves if you're handling loose contaminated instruments like in a central sterilization area. So personal protective equipment, of course, the mask is going to work best when it's over your mouth and nose, not under your chin, not in your side pocket that you tote from room to room. Masks are single-use disposable items. So that means one time they're used and they are tossed. CDC guidelines tell us that once that mask becomes wet, and that can even be with you breathing in and out for the moisture, then that mask is tossed. Usually about an hour's worth of the mask, and then you have to toss it. Keep in mind, manufacturer's instructions also play a role in that. I have seen some brands of masks that actually say on the box that after 1 hour of use, cross-contamination could occur. So after 1 hour of use, you should replace that mask. So keep in mind that you do have to also watch manufacturer's instructions. Oh, I got another question. This is a good one. Do you recommend this is back to the hepatitis B vaccination. Do you recommend keeping all hepatitis B paperwork together in case of an audit or in the employee's file? It should always be kept in the confidential employee medical file. And I'm actually going to talk about that in just a little bit. That's part of the requirement of the standard is the medical employee's file. So we're going to get there. And thank you for that question. But yes, you keep it in the employee's file. You would have to just go pull them in case of an audit. So back to personal protective equipment. We got your mask, and I went over that. Single use, always follow manufacturer's instructions. Same thing with patient exam gloves. They're single-use disposable items. You should not try to reuse gloves on different patients. You should not be washing them with soap and water and trying to reuse them. They, again, are single-use disposable items, one time, one use, and they are tossed. Eyewear is very important when you are doing any procedure that creates splash or splatter, and keep that in mind when you are in like your central sterilization area. A lot of times people will have masks on, goggles or eyewear on during a procedure, but then once the procedure is complete and they go to start processing their instruments, they take eyewear off, or you're in there processing instruments with that ultrasonic going and water going and splashing and spraying. So always use eyewear. I don't find that to be as big of an issue in facilities any longer when I go in them, but the only issue I find, the biggest issue with that, is they're not cleaning and disinfecting those between cases. You can wear your prescription glasses. They're fine. However, again, depending on what type of splash and splatter and how much you are creating, you may need to have on solid side shields, as you can see in his right here on the side. of this guy's glasses. He has on solid side shields. Some masks have a face shield over it that could be covered also. Your lab jackets or lab coats, again, are supplied and maintained by your employer. So these are disposable gowns or lab jackets. So you would use those and then toss them into your regular trash can. Utility gloves are actually OSHA required. That is a requirement when you're handling loose contaminated instruments. So in that central sterilization area, you would definitely want to have on your utility gloves when you are helping to process those instruments. You would need to have training on personal protective equipment when a new employee comes aboard, letting them know what is offered to them, what type of personal protective equipment is utilized, and then based on the tasks they're performing, what personal protective equipment they should have on. And the accessibility, properly cleaning, laundering, repairing, and disposed of is at no cost to employees. Again, employers supply personal protective equipment for their occupationally exposed employees. So an exposure has occurred. Keep in mind that that exposure could not only be just a stick with a contaminated needle or a stick with contaminated sharps. It could be a cut with sharp objects that are contaminated with blood or other potentially infectious material. The things I don't think we think about is that blood splash or other potential OPIM is other potentially infectious material splashed to the mucous membranes of the eyes, nose, mouth, or non-intact skin. All of these would constitute an exposure. So do you have a post-exposure management plan already in place? That is one thing that I always encourage you to do, because there's certain things that you would need to consider during a post-exposure process. And remember that exposure of needle stick, sharps injury to blood or other potentially infectious material, blood splash to the eyes, nose, mouth, non-intact skin, or saliva splash, or other bodily fluids that are possibly contaminated, all constitute that exposure. So what do? I recommend that you go ahead and establish in advance a relationship of who would provide a post-exposure process and consultation and evaluation for your exposed employee and the source patient. Now, some facilities do manage these in-house, and you can do that in-house. That's fine. But if you are going to outsource that to another facility, I would recommend an occupational medicine or an urgent care or faster care. Sometimes emergency rooms, you could sit there for hours on end. They may not even know the standards of what to do. So if you're outsourcing your post-exposure management and evaluation, I would highly recommend that you go ahead and set that facility up ahead of time so that they know what you would need from them, and you know exactly where to send your exposed employee and or the source patient if needed. That relationship in advance would consider that your employer pays for the services of that post-exposure evaluation and management. A rapid HIV testing for source patients is a great little thing to have. That way you know within minutes if that source patient has test positive for HIV. What do you need to do? What would they need to do if they tested positive for HIV? More than likely, they're going to start you on antiretroviral drugs. And again, that is another important question. Are the antiretroviral drugs available at that facility? How do they get you started? Where is the availability of all that medication? And you would always want to get the most current guidance on bloodborne pathogen exposures from the CDC. Now, the CDC's website, by the way, is www.cdc.gov, cdc.gov, and there would provide you with the recent guidance on the do's and don'ts. And then, of course, the physician who is in charge or who you are sending your facility, your employees to that facility, they also would make their professional judgment call on how to handle the post-exposure process, and hopefully they should be following that, again, that guidance on the exposures. So you would want your employees, again, the first step would be to clean the area or flush the area if it was a blood splash or other potentially infectious material splash. Where's the closest eye wash? Do you have a working eye wash in your facility? They would clean any needle sticks or sharps injuries with soap and water. No pouring bleach like we used to do in the long time ago. Don't do that anymore. Soap and water is all the CDC says. So you clean your area. You would flush if it was a splash. You're going to report it. Does everyone in your facility know who to report an exposure incident to? Do you have a safety officer already in place? So everyone should know who to go to about their incident. And then the requirement is from OSHA that you offer a baseline testing and counseling to all exposed employees. If the employee does not move forward with treatment, they should be asked to sign a declination of care, and that declination of care would be kept in their employee medical record. Your source patient, if they're known, would have testing for hepatitis B and C and HIV, and the test results of that exposed source of that source patient would be shared with the healthcare provider for the exposed worker. If the source patient tests negative for Hep B, C, and HIV, of course, all testing would stop, and you would not have to move forward with that. And there are a lot of ins and little tidbits with the testing and the post-evaluation, post-exposure process on that. So I would always recommend, of course, that you follow the CDC guidelines, and you can get those on their website, because there are certain, like if your exposed employee has immunity to hepatitis B, you would not have to test that source patient for hepatitis B. You would just go with the hepatitis C and the HIV and move forward. So just keep those kind of things in mind, that you would want to have the most current guidelines on a post-exposure process in place, and you know what you would do immediately if there was an exposure. And again, just like a hepatitis B vaccination, you have to show OSHA that you offer that to your employees, but they can sign a declination if they do not want to proceed with the hepatitis B vaccinations. Same thing with the post-exposure process, a declination of care, and that would be kept in the employee medical record. There are laws in each state, by the way, for source patient testing. Some states, you can make your patient go be tested, the source patient. Just kind of want to throw that out there. So you always want to follow your state specific laws also about that. If you have any questions about that, you can always email me, and I'll give you my email address. And I do not know specifically each state that has that requirement, with the exception of North Carolina. North Carolina is one that the source patient, you could get your state health director involved, and if your source patient did not want to be tested, they will go get them and make them test at times. So again, there's different laws on the source patient about during the post-exposure process that you would need to follow. Are there any questions about the post-exposure process at the moment, or everybody? making sure I answered all the questions. Yes, I have. So far, so good. Okay, happy Friday. We're moving right along. So the medical record. This is your employee medical record. This is an OSHA requirement that you keep an employee medical record for all employees that have a risk of an exposure to a bloodborne pathogen. It is a confidential file, a confidential record. It is not stored with the HR file or with the medical file in the office or with, if they're a patient also, or like in dental facilities, sometimes I'll see them try to keep their files, employee medical files, inside their dental record. It is a separate file. It is confidential. I had a question. What are the OSHA requirements on keeping electronic medical records versus paper medical records? They do not have a requirement on that. You could keep electronic or paper. You would just need to be able to get to them if you need them in a situation. So electronic records are great, but again, of course, I know we're all at the electronic age and electronic health records and whatnot. As long as your computers are up and running, you're great. But you would need to be able to access that record or keep the record until you could get it in the electronic format in the case of an exposure. But they do not have a requirement on that unless that you're a certain state. And again, OSHA is a federal. I'm discussing federal guidelines today. Some states have their own state regulated OSHA programs, and unless they have a specific on that, but federal does not. Great question, by the way. Y'all are really asking some good questions today. I like it. On Friday. Sometimes people are quiet on Fridays, so that's good. Happy Friday. All right, so back to your medical record. Again, it's a confidential file. It's not shared with everyone in the office because it does include the employee's name, social security number, a copy of that hepatitis B vaccination status, and if you don't have that, you would keep that declination where they decline the vaccine from you. And let me say this, sometimes I go in facilities and employees get a little offended about that declination statement. It's not declining necessarily the vaccination, but you are declining it from that employer. You have to prove that the employer has to prove that they have offered you that vaccination. So for someone like me, if I couldn't give you a titer, but I knew I had my vaccinations and I didn't want to repeat those, I would sign a declination of care because I don't want to go through the vaccinations again. So I'm hoping that is not an issue for you in your office. But again, they're not necessarily declining the vaccination. They're just declining it from you, from that employer. And that employer has to have something on file stating that they offered it to the employee to prove that they offered that to the employee. Any incident reports that are done, any post-exposure follow-up or consultations, all of that is kept inside. Are we still required to include the Social Security number in the employee medical record? That has not changed, so the answer to that would be yes, employee name and Social Security number. All incident reports, again, anything that happens, you would keep that in the employee record. A copy of information that's provided to the healthcare provider for exposure evaluation and all of the results of the exams or the medical testing and follow-up procedures. And also the employer's copy of the healthcare professional's written opinion. And then this is the one that gets everybody, OSHA loves a little keeping records. So employee medical records should be kept 30 years past the final employment date. So 30 years past the final employment date. And there are written protocol in that standard telling you what to do if you sell your practice or the physician retires or whatnot. What do you do with those records? So you would look in the bloodborne pathogen standard and it tells you what procedure to follow in that case. But they are to be kept for 30 years past the employment date. All employees who are at an occupational exposure risk should have bloodborne pathogen training annually, once a year. OSHA actually goes on to say that should not even exceed the 365 days. So they mean within once a year. Employee training is provided at no cost to the employee during working hours. It should also be provided at the time of the initial assignment to where the task, where those exposures may occur. And also you should ask, they should be allowed to ask questions and get their answers from the person conducting that training on the bloodborne pathogen standard. I've actually seen OSHA inspectors, when they go into facilities, they can not only ask questions to the safety officer, but I have seen them ask other employees questions, and that has actually been one of the questions they've asked during the training, where you provided the opportunity to ask a question and get your answers. So you would, of course, I was able to ask questions and get answers, but they will pull other employees aside, not necessarily just that safety officer, and ask questions. So that's something you would have to look for in an OSHA inspection. Hopefully you'll never have an OSHA inspection, but if you do, don't panic. Again, they always start out with these written policies, and we're looking at that. So your training records basically need to have this on them. Of course, the dates of the training, the contents or summary of the training sessions, what was covered in the training, the bloodborne pathogen standard. Did you cover work practice controls, engineering controls, the exposure control plan, and so forth? So what did you cover during the training sessions should be listed there. And then the names and qualifications of the person conducting the training. They would like to see that. I get that question a lot. Can I train my staff? You can, as long as you can show OSHA what your qualifications are to conduct that training and the contents of what you have covered. Names and job titles of all persons attending the session. Job titles, mainly you want to know if they are at that occupational exposure risk. Sometimes administrative staff members sit through the bloodborne pathogen training, which I think is awesome that the entire team does it. But job titles, they want to see, and they're ensuring in that to make sure all clinical members have had the training. And then all training records should be maintained for 3 years from the date of which the training occurred. So that is the one thing OSHA does let us keep for not so long. The 3-year mark is your training records. Again, employee medical records have to be kept 30 years past the last date of employment. And the bloodborne pathogen standard does not cover hazard communication or the chemicals that you come in contact with. But those safety data sheets or material safety data sheets also should be kept 30 years past the final date it was used, or at least a list identifying the chemicals. So OSHA does like the little 30-year mark, with the exception of the training records, 3 years. Again, your exposure control plan has to be annually updated. Don't forget that portion of your meeting your requirements with your written policies and procedures. Annually updated the exposure control plan. I will now take even more questions if you have them. I'll be more than welcome. You're welcome your questions actually on this Friday. We have a few minutes, I believe, Erin, to where we could open that up.
Yes, we actually do.
Go ahead.
I wanted to, I see someone's typing, but I wanted to take a second and thank Mary McCloskey and her 11th grade class at St. George's Technical in Middletown, Delaware, for joining us today. So we have a really robust group of practice managers and other administrators on the webinar today, but also a group of 11th graders who are studying to be in the field of healthcare management when they graduate. So I wanted to welcome them and thank them for joining along. We're happy to have you. Are there other questions for Renee?
And Erin, I'm going to touch on that with the 11th graders. I think that's awesome that you were there, by the way, and that they're interested enough to attend that webinar. So good for you, 11th graders. If I was there, I'd give you all gold stars.
And good for their teacher, I'd like to say, too. That's to give them this kind of exposure is really awesome for their teacher, too, I think. And yes, yes, Kimberly, the presentation and the recording will be emailed to all of the participants. Usually it takes us a few days, so probably midweek next week you'll get a recording and the presentation emailed to you. They'll also be available on the member state websites through the members that you registered through. There's a question down there from Lisa. Renee, do you see that?
I do. I was just reading that. They use an online training module for bloodborne pathogens. It sounds like we are required to perform this as a live training. Is that correct? Not necessarily. Lisa, if you're doing an online training module, that's great, but how do you ask the questions is what you would have to show OSHA. Is there someone attending the training that feels like they could answer those questions, or would you have to email them? I do like live trainings a little easier just because you can ask those questions and get your answers, but you may have someone in attendance in the audience that could answer questions. So if they feel like they can answer them and they have the qualifications to answer those questions, you may be able to do it that way for your staff. That's actually an excellent question.
Okay. I took care of Linda. I'll get in touch with her after the webinar. Steve, we can issue a certificate, a CEU certificate, and any of your member states can as well. I'm not sure which member state you registered through, but if you shoot us an email or shoot your member state an email, they will be able to give you a CEU certificate for the webinar. But then there are two questions from Lauren and Linda. Renee?
Yeah, Lauren. This question, should these medical records be separate from other medical records you keep, such as workman's compensation and disability? And workers' compensation, again, if it's an injury and exposure at work, then you could keep it in that employee medical record, but all others, I would probably make a separate folder for that. What are the penalties, Miss Linda, was your question? Oh, that's a great one. I have seen penalties with OSHA in different states range anywhere from $100 to thousands. Usually 10,000 is about the max you will see, but that would have to be a big one. I will tell you this, I saw in Tennessee there was a fine in a facility. They were not monthly inspecting their fire extinguishers and signing off on the tags on the back, and so that facility was charged $200 for not doing that. OSHA, the utility gloves are required, and if they come in your facility, for each employee that they observe not wearing utility gloves, handling those loose contaminated instruments, I've seen them cite that an office per employee. It's not an overall fine for utility gloves. It was per employee. So just kind of depends on if you've got state laws or your federal, and a lot of times it depends on the inspectors. I hate to say it that way, but that could be so very true. So from hundreds to thousands I've seen. Just depends on your citation, your issue.
A question there about
standard for, I don't know, I guess everybody can't read those questions, but what is the standard for cleaning, sterilizing, and maintaining utility gloves? The standard for that, utility gloves, you can autoclave them, you can spray them down, you can wash them however you want to clean and disinfect those. Of course, if they become cracked, peeled, or torn in any way, you would want to discard them and get and get new utility gloves. But the utility gloves should not be, they're not talking about the Playtex gloves you get from Walmart or Dollar General that you wash dishes with. The utility gloves should be puncture resistant, chemical resistant gloves that you purchase. So most of those, all of those, I believe, can be autoclaved. So autoclaving them or washing them, spraying. Some people spray them with Cavicide, Opticide, whatever you use in your facility. Well, thank you, Linda, for that comment. I appreciate that.
We'll take, is Mary Kay, it looks like we had one more question coming in. I'll give it 1 second.
Okay.
1 more minute there. You see that, Renee?
I do not have a template for an office policy, Mary Kay. You could go to OSHA.gov is where I would start with that. www.OSHA.gov, and they may have a template. If not, you can download your Bloodborne Pathogen Standard for free there and print it off.
Well, I want to thank everyone for joining us today. Thank you to the everyone who attended, and thank you to Renee. I have to say this has been a great crowd, so to speak. Lots of great questions. The link to the recording and the presentation should be distributed by each state affiliate through email. Following the webinar, you'll be sent 2 brief surveys. One will ask you to rate the webinar using a 5-star scale, and another, you will be sent a separate email and link to our online webinar survey where you can give us feedback about today's presentation. Please take a few minutes to complete both. If you're a non-member, please consider becoming a member of your respective state affiliate. This concludes our webinar. Thank you.